Imagine a patient walks into a clinic, right, with this mysterious lump on their neck.
Right.
And you would think the immediate next step in modern medicine is pretty obvious. Like the doctor orders an x-ray. Or maybe they send the patient down the hall for a high-resolution MRI or
You
something.
expect that, yeah.
Yeah, you expect that clean binary digital image to do the heavy lifting for the diagnosis. But instead, the doctor does something that sounds incredibly antiquated. I mean, they ask the patient to stick out their tongue, they watch them swallow, and then they grab a simple flashlight.
It does. I mean, it sounds almost primitive, doesn't it?
It really does.
Yeah.
But today, we are looking at actual clinical training material to prove this exact sequence of events is, anything but basic.
Yeah, it is in fact a masterclass in observation. We're diving into the exact step-by-step guidelines and sample medical charts used to train doctors on how to evaluate a neck or a thyroid swelling. And navigating this diagnostic landscape relies intensely on human senses, but it's structured with incredible scientific rigor.
Welcome to the deep dive. Our mission today is to decode how doctors are trained to transform a simple physical lump, which is, let's face it, a complete medical mystery, into a highly detailed standardized data set using literally nothing but their eyes, ears, and hands.
Yeah, it's amazing.
And whether you are a medical student prepping for rounds, or just someone who, like me, loves understanding how experts decode the complex world in front of them, this deep dive is going to completely change how you think about a standard doctor's visit.
Okay, let's unpack this. Because right at the top of these training notes, before the doctor even begins the physical exam, there is this brilliantly simple guiding philosophy about how to organize the data.
There really is. The training text states this explicitly. It says, the easiest way to examine a swelling is to examine it in the sequence in which it will be described.
Yeah, the candidate, the doctor in training, essentially, is instructed to mentally draft their final clinical report as they are performing the physical checks.
That is such a fascinating cognitive strategy.
It really is, yeah. It forces the brain into a highly systematic loop. If a doctor observes the patient in the exact rigid order that they're required to report their findings later, they literally cannot miss a step.
Right, because they're filling out the form in their head.
Exactly. They don't have to retroactively try to remember a detail or organize their scattered thoughts after the patient leaves the room. The observation itself becomes the organization.
It builds the blueprint while you are walking through the house, basically.
I like that, yeah.
And looking at the guidelines, this sequence starts before the doctor even lays a finger on the patient's skin. We are talking about the pre-flight checklist.
Right.
The text emphasizes the introduction, getting consent, ensuring proper exposure of the neck area.
Yeah.
But from there, I would have assumed the doctor just starts feeling the lump.
Most people would.
Right. But instead, the protocol dictates very specific tests for the eyes and the ears first. It highlights literally 2 tests to listen and 3 tests to see. So before we touch, we are just listening to the patient's airway.
Because observation is crucial data collection, and the neck is, well, it's the primary bottleneck of the body.
Literally.
Yeah. The 2 listening tests are having the patient take deep breaths to check for a sound called stridor, and having them count to 5 to check for hoarseness.
Stridor.
Yeah, stridor. When a doctor asks the patient to take a deep, forceful breath, they're stressing the airway to see if the internal diameter has been compromised.
Oh, I see.
Stridor is a harsh, vibrating, almost musical sound that occurs when air is turbulent. If you hear stridor, it means that lump on the outside is pressing inward, physically narrowing or obstructing the windpipe.
Oh, wow. And having them count to 5 isn't just about hearing them speak, is it?
Not at all.
It requires sustained rhythmic engagement of the vocal cords. Like, it stresses the vocal machinery just enough to see if the internal structures or, the delicate nerves controlling the voice box are being paralyzed or pinched by the swell.
Exactly. Then the protocol moves to the visual tests, the 3 tests to see.
Right.
The doctor asks the patient to swallow a sip of water. They ask the patient to stick their tongue out, which the text refers to as tongue protrusion. And finally, they have the patient perform the Valsalva maneuver.
The Valsalva maneuver.
Yeah, which involves the patient bearing down, similar to the pressure you create when you're going to pop your ears on an airplane.
It really reminds me of a mechanic running a diagnostic on a car engine.
Oh, how so?
Well, when you first bring a car into the shop, a good mechanic doesn't immediately grab a wrench and start unbolting the radiator.
True.
They turn the car on, they listen to how it sounds while idling, then they rev the engine. You aren't taking the machinery apart yet. You are just seeing how the machinery operates under different mechanical conditions.
Yeah. That's a great way to look at it. What's fascinating here is the underlying anatomy driving these specific mechanical conditions.
Right.
The neck isn't just a static column holding up the head. I mean, it is a super highway of moving parts, muscles, and glands.
Right, yeah.
When a doctor watches a patient swallow, the entire thyroid gland and the structures attached to the windpipe are pulled upward by the throat muscles.
Okay.
So if the visible swelling moves up and down when the patient swallows, the doctor instantly confirms that the mass is anatomically attached to the thyroid or the trachea.
That's brilliant.
The tongue protrusion test works on a similar mechanical principle.
Because sticking out your tongue pulls on different internal structures than swallowing does, right?
Precisely. During our embryonic development, the thyroid gland actually starts at the base of the tongue and moves down into the neck, leaving behind a small tract called the thyroglossal duct.
Wait, it starts at the tongue and moves down?
It does, yeah. And sometimes a cyst can form along that leftover tract.
Yeah.
Because that duct is physically tethered to the base of the tongue. If a patient sticks their tongue out and the lump in their neck darts upward, it is a massive, definitive clue about the embryological origin of that swelling.
That is wild.
And finally, the Valsalva maneuver increases pressure inside the chest cavity. If the lump expands or bulges out when the patient bears down, it suggests the mass is connected to the venous system, like a dilated vein, because the blood is being pushed back up into the neck.
You are literally watching the internal plumbing work from the outside, just by having someone swallow or hold their breath.
Exactly.
So we've looked and we've listened. The diagnostic sequence now dictates moving from distant observation to direct physical contact with your palpation.
Right, the hands-on part.
And I noticed a very specific instruction right at the top of the palpation section. It explicitly tells the doctor to warm your hands by rubbing them together before touching the patient's neck.
Yeah.
Which, that sounds like a basic lesson in bedside empathy. But based on everything we've discussed, I suspect there is a highly technical reason for doing this.
You're right on the money. Empathy is vital, of course, but you are absolutely right to suspect a diagnostic utility.
I knew it.
Yeah, a cold hand placed suddenly on the sensitive skin of the neck causes the patient's underlying muscles to flinch and tense up involuntarily.
Oh, sure. You jerk away from the cold.
Exactly. And if the muscles are rigid, it completely ruins the doctor's ability to feel the subtle, soft tissue structures underneath. Warm hands ensure the tissue remains relaxed and pliable, allowing for accurate tactile data collection.
That makes perfect sense. The environment has to remain neutral. So hands are warm, consent is given, and the examination begins by checking the temperature of the swelling compared to the surrounding skin and noting any tenderness. But then, the doctor has to map the geography of the lump using a specific mnemonic detailed in the text: SMS, surface, margins, and shape. And this is where the vocabulary goes from casual description to intense clinical precision.
The vocabulary is the tool that standardizes the finding.
Okay.
For surface, the doctor is feeling the texture of the boundary. Is it perfectly smooth? Is it irregular? Or is it what they call lobulated?
Lobulated.
Yeah, meaning it feels like it has multiple rounded compartments grouped together, almost like a cluster of grapes or a raspberry.
Oh, vividly gross, but very clear.
Right. When evaluating margins or edges, the doctor determines if the borders are poorly defined, sort of fading ambiguously into the surrounding tissue, or if they are well defined where you can trace a sharp, distinct boundary. Finally, shape categorizes the mass as spherical, ovoid, or completely irregular.
Got it. And right after the SMS check, the text says to test the consistency. Is it soft, firm, hard, or, I love this phrase from sample charts, is it firm to hard?
Oh.
That feels like such a beautifully nuanced clinical distinction.
It captures a very specific physical reality. A soft swelling might feel like a lipoma, a collection of fat. A hard swelling swelling feels completely unyielding like bone or cartilage, which can sometimes indicate a malignancy. Firm to hard falls right on the spectrum between dense, fibrous tissue and something solid. It is not squishy like a fluid-filled cyst, but it isn't rock solid either.
Okay, so the doctor has mapped the surface, the shape, and the density. But the next section on mobility and fixation is where the mechanics of palpation really break from simple touching and become a complex investigation of depth.
This part is crucial.
The tech instructs the doctor to test if the overlying skin is fixed by trying to pinch it, and then check if the swelling is fixed to underlying structures in both horizontal and vertical planes. But then it adds a step that involves asking the patient to contract their neck muscles. It says to note if the swelling doesn't change its size on contraction of underlying muscles, or if it becomes less prominent on contraction.
This is a beautiful piece of diagnostic logic. The doctor is using the physics of human anatomy to see beneath the skin.
I have to admit, I initially struggled to visualize this.
It can be tricky.
But it's essentially like trying to figure out if a small pebble is resting on top of a bed sheet, or if it's hidden underneath the bed sheet.
Oh, I like that.
If the pebble is resting on top of the sheet, and you pull that sheet incredibly tight, the pebble is pushed upward and becomes even more prominent.
Right.
But if the pebble is hidden underneath the fabric, pulling the sheet tight creates a rigid barrier over it, making the pebble suddenly disappear or become much harder to feel.
That is an excellent way to conceptualize it. The thick muscles running down the side of your neck are the bed sheet.
Okay.
If a mass is located deep to that muscle, meaning it is underneath it, asking the patient to turn their head against resistance causes that muscle to flex, becoming tight and rigid like a shield. Because the muscle is now a hard taut barrier over the top of the mass, the lump underneath it suddenly becomes harder to palpate. In the clinical language of the text, it becomes less prominent.
And if the lump is sitting on top of the muscle, just below the skin, flexing the muscle pushes it outward, making it more prominent.
Exactly.
By just making the patient flex their neck, the doctor's hands can determine the exact depth and structural attachment without making a single incision. It is brilliant.
It really is.
And to finish the palpation sequence, the doctor runs through a rapid-fire checklist of negatives. They have to confirm if the swelling is non-pulsatile, non-fluctuant, non-reducible, and non-compressible.
Yes, the negatives.
And again, this is just a list. I mean, each of these terms represents a distinct physical test for a different kind of internal threat.
They are essentially ruling out entirely different categories of disease. Checking if a mass is pulsatile means feeling for a rhythmic expansion that matches the patient's heartbeat.
So if it pulses like a heartbeat.
Right, which would indicate the mass is an aneurysm or a highly vascular tumor attached to an artery.
Okay.
Checking for fluctuance involves a very specific two-handed technique. The doctor presses on one side of the mass to see if they can feel an outward bulge on the opposite side.
Oh, like displacing water.
Yes, if they do, it means they are displacing liquid. It tells them the mass is a fluid-filled sac like a balloon filled with water, rather than a solid piece of tissue.
And what about reducible versus compressible?
Yeah.
Because to a layperson, those sound like the exact same thing, just shrinking a lump.
They sound similar, but mechanically they are entirely different. If a mass is reducible, it means you can physically push the protruding tissue back through a structural gap into another bodily cavity. Think of a hernia.
Oh, sure.
You apply pressure, and the lump slides back through the muscle wall where it belongs.
Yikes.
Yeah, but if a mass is compressible, it means the mass itself can be squeezed down to a smaller size, much like a sponge, but it stays in the same anatomical location and expands back out when you let go. A vascular malformation full of blood might be compressible, but it isn't reducible.
So once the hands have gathered every possible piece of tactile data, ruling out fluid, ruling out hernias, mapping the borders, the doctor finally brings in the toolkit.
Finally.
But even then, looking at this training material, the technology is remarkably low tech. The text lists exactly 3 instruments.
The tools are simple, but the application is highly specialized. First, they use a foot or ruler to measure the size of the swelling in exactly 2 planes, establishing highly accurate dimensions. Second, they use a stethoscope to listen directly over the swelling for a bruit.
And a bruit is a specific type of vascular murmur, correct? What exactly does that sound like through the stethoscope?
It sounds like a rushing, whooshing noise. Normally, blood flows smoothly and silently through your arteries.
Right.
But if a tumor or an enlarged thyroid gland has developed a massive network of new, chaotic blood vessels to feed itself, that heavy, turbulent blood flow creates a whooshing sound with every heartbeat. Hearing a bruit instantly tells the doctor they're dealing with a highly vascular active mass.
Which brings us to the third and final set of instruments: a simple torso, a flashlight, and an X-ray roll. And the instructions in the manual are brilliantly specific about this. They dictate that the flashlight and the X-ray roll should be placed at an angle of 180 degrees to each other to check for something called transillumination.
This is a classic, elegant medical trick that utilizes the physics of light to determine internal composition.
That's so clever.
It is. The doctor places the bright flashlight firmly against one side of the lump. Then they take an old piece of X-ray film, roll it up into a hollow tube, and place one end of the tube against the exact opposite side of the lump, 180 degrees away.
And the reason you use the rolled up X-ray film is just to block out the ambient room light in the clinic, right? Like looking through a telescope.
Exactly. You look through the dark tube to see if the light from the flashlight is making it all the way through the mass. If the lump glows warmly in the darkness like a paper lantern, it means it is filled with clear fluid, which scatters the light, it transilluminates. But if it stays completely dark, it means the mass is solid tissue or filled with blood, which absorbs the light. It is non-transilluminant.
It is basically a makeshift external ultrasound using nothing but a flashlight and a piece of plastic.
Pretty much.
But here's where it gets really interesting, because the text then outlines the next massive phase of the examination. Look for cause and effects of swelling. And this is where the biological logic forces a massive shift in perspective. The doctor's hands and tools have told them everything possible about the local geography of the lump. But a swelling in the neck doesn't exist in a vacuum.
Not at all.
It is deeply connected to the body's master control systems. And that is why the doctor suddenly moves away from the neck entirely and starts checking completely different parts of the patient's body.
The diagnostic lens goes from a micro view of a single lump to a macro view of the entire human organism.
First, they check the position of the trachea to see if it's being pushed off center. They feel for laryngeal crepitus, which is that normal rough crunching feeling you get when you move the voice box gently from side to side.
Right.
If that crunch is missing, it means a tumor might be acting like a cushion behind the airway. They look inside the oral cavity, they use instruments to look down at the vocal cords and up into the back of the nasal passages. But then, you look at the sample chart for other findings, specifically in the thyroid exam, and the checklist takes us down to the patient's hands and feet.
It is a staggering leap geographically, but it makes perfect physiological sense.
It's wild. The chart mandates checking if the patient's palms are unusually sweaty. The doctor takes the pulse rate. The sample chart notes the perfectly normal 80 beats per minute, regular.
Right.
They hold out the patient's hands, laying a piece of paper over their fingers to look for fine tremors. They closely examine the eyes for something called lid lag or lid retraction. They check the spine for tenderness.
All over the body.
Yeah, and the checks that really stand out to me, they use a reflex hammer to tap the knee and the ankle to check the deep tendon reflexes, and they press their thumb firmly into the skin around the ankles to look for pitting edema.
If we connect this to the bigger picture, this is where the absolute brilliance of clinical medicine shines. The thyroid gland, which sits right there in the neck where we've been examining the lump, is the metabolic engine of the human body.
Okay.
It produces hormones that regulate how fast your heart beats, how fast your nervous system fires, and how your body manages fluid. If that localized lump in the neck means the thyroid gland is malfunctioning, the effects are not local, they're entirely systemic.
So a localized physical problem creates a whole body chemical problem.
Precisely. If the thyroid is hyperactive, pumping out far too much hormone, it essentially throws the body's engine into overdrive. The nervous system gets jittery and overstimulated, which causes those fine hand tremors and makes the knee reflexes wildly hyperactive when tapped with a hammer. The heart rate spikes. The body runs hot, causing excessive sweating in the palms. The muscles behind the eyes can even swell and pull back, causing that prominent lid retraction or bulging of the eyes.
And if the thyroid thyroid is sluggish or underactive, it does the exact opposite.
Exactly.
Which explains why the doctor is pressing on the patient's ankles, looking for pitting edema. And pitting edema is a fascinating physical sign. It's not just regular swelling, is it?
No, it's very specific.
When a doctor presses their thumb into the fluid accumulated around an underactive thyroid patient's ankle, the fluid is displaced so slowly that when they remove their thumb, a deep indentation remains in the skin for several moments, like pressing your hand into a memory foam mattress.
That memory foam effect tells the doctor exactly what kind of proteins and fluids are accumulating in the tissue. By examining the bounce of a knee reflex, the sweat on a palm, or the indentation in an ankle, the physician is gathering vital, undeniable clues about the chemical havoc that the lump in the neck is wreaking on the rest of the body.
It is like studying the fading leaves at the very top of a tree to diagnose a slow rot happening down in the roots. The entire organism tells the story.
I love that analogy.
And to demonstrate how all these granular details, all these seemingly disconnected checks, finally coalesce into a singular diagnostic picture, the training material provides 2 sample patient descriptions. And this is where the ultimate value of this standardized routine becomes incredibly clear. We see exactly why the sequence matters.
Right, we reach the final portraits of the patients.
When you look at these final charts, the contrast is amazing. Patient 1 is described as a young female of average build. Patient 2 is an elderly man.
Okay.
Demographically, they occupy entirely different universes. But because of this rigorous system, their physical exam notes read like they were generated by the exact same diagnostic machine. The subjective human element, like any bias about age or gender, is completely stripped away.
The clinical data becomes the only focus.
For both the young woman and the elderly man, the charts methodically rule out every variable we've discussed. They both describe a swelling that moves on swallowing, definitively connecting it to the throat mechanics. Following the SMS rules, both describe the mass with the exact same objective vocabulary. Quote, a 2 by 2 centimeter, solitary, spherical, firm to hard swelling.
Wow.
Yeah, both notes confirm the swelling is non-pulsable, non-fluctuant, and non-transilluminant. Eliminating aneurysms insists from the equation. The subjective observer is removed, leaving an unambiguous 3D map.
And that is the ultimate triumph of this entire process.
Right.
This standardized reporting ensures that medical data is recorded in a universal language. By strictly adhering to the SMS vocabulary, mechanical tests for mobility, and the systemic observations of the hands and knees, any doctor anywhere in the world reading these notes instantly visualizes the exact same 2 by 2 centimeter solid mass.
It's incredible.
It completely eliminates guesswork and paves a clear, scientifically rigorous path toward accurate treatment.
We started with the simple act of warming cold hands to prevent muscle flinching. We walked through the listen and see tests of breathing and swallowing and unpacked the mechanics of the SMS rules of palpation. We learned how to use a flashlight and rolled up plastic to see through tissue. And finally, we tracked a localized neck lump all the way down to the systemic clues of sweaty palms and sluggish ankles. So what does this all mean for you? Well, the next time you are sitting on an examination stool and a doctor asks you to stick out your tongue or swallow a sip of water or taps your knee with a hammer when you're complaining about a lump in your throat, you are going to know the exact mental checklist that physician is running through. You'll know they're building a precise 3-dimensional model of your anatomy in real time.
This raises an important question for us to walk away with. In an era where we increasingly and rightfully rely on MRI machines, blood panels, and artificial intelligence to tell us what is wrong inside the human body, what is the irreplaceable value of a doctor who simply knows how to use a torch, a stethoscope, and their own 2 warm hands to truly observe a patient?
The digital machine might give us the clean, binary answer, but it takes the highly trained human senses to navigate the complex, interconnected reality of a living, breathing system. Thank you for joining us on this deep dive into the art of clinical observation. Keep looking closely.